the meeting. We have established in the World Spinal Column Society a spine board meeting to discuss cases every third Sunday of each month. Now we are on the 8th consecutive month, and we will continue like that every third Sunday at the same time. I would like to present the other two coordinators. I have in front of me Said Naideri. He is a professor from Marmara University in Istanbul, Turkey. And he's a renowned spinal surgeon who is very much focused in this subject. On the other hand, we have Ruli Hanafi Dahlan, who is also a professor in Bandung University in Indonesia. And he will be the host for the next World Spine meeting next December in Indonesia. And we are all looking forward to attend. And I am Vasilis Likomitros. I work at the Thessaloniki private hospital in Greece, and I'm an orthopedic surgeon specialized in deformity surgery. So we can start with, we have today, it's an exceptional day. We have 4 cases, and we will start our first case with Professor Said Naideri presenting the case from Professor Jorge Salazar, who is a chief neurosurgeon in Quito, Ecuador.
Okay.
Please.
I would like to share my
Screen?
Yes. Okay. This case is actually the case of Professor Salazar. I would like to summarize this. There is history. This is a 40-year-old woman who complains of chronic low back pain and was diagnosed as disc herniation and refused surgery. Last several months, pain increases with irradiation to the left lower limb. That means the case has low back pain and left leg pain. Examination revealed severe pain in the low back. VAS score is 8. LASEK test is positive in the left side. And I would like to show you images. Actually, we have only 2 sagittal view and 1 axial view. And what I can see here in sagittal view, which is in the midline view of the spine, lumbar spine, there is some modic changes around the L5-S1 intervertebral disc, and disc is black in the L5-S1, and there is narrowing of the L5-S1 space also. There may be a small herniation here, but we don't have any paramedian slices of the MRI. We have only 1 axial view you can see here, and here you can see a small bulging here in the L5-S1, and maybe 1 disc in the foraminal zone. So Dr. Salazar, based on these images, planned transpedicular biopsy of L5 in order to see if there is any infection. That means he, according to him, these changes might be infection. And unfortunately, there was no bacteria, no TB, no other infection in the test. So he has some questions for the board. What is the differential diagnosis for TB, bacteria, immunological, or rheumatological changes? And the question number 2 is, what is the next diagnostic procedure? And number 3, is an antibiotic prophylactic treatment justified? Is the Dr. Salazar here? I think if he is here, we can ask if there is anything to add to these slides. Is he here? Dr. Vasilis?
No, he's not here. I sent him also a message. And let's continue to the discussion, what everybody thinks.
Okay. Actually, I would like to analyze the cause of the left leg pain in this case. As you can see here, we have only one sagittal MRI at the level of the midline. If it is disc herniation causing severe left pain, we need paramedian view of the sagittal MRI of the lumbar spine. Unfortunately, we don't have. But here, when we have only one axial view, here in the axial view, you can see a very small herniation. I'm not sure if there is compression to the nerve root here. But this is actually, this slice is at the level of the pedicle. It's not to show herniation. Actually, it was to show these changes, which I think they are modic changes. But in order to understand the cause of the left leg, we need to all MRI in the sagittal and the lumbar view. We may see herniation in the paramedian area, and in some cases, if there is not herniation here, we need to check for herniation at the foraminal level or in the far lateral level. This is very important. I would like to show you one case. For example, this is a far lateral case, far lateral foraminal case. You can see here at the foraminal level, you can see in the left side herniation at the foramen, and in axial view, you can see broad-based herniations. Sometimes you can see better far lateral herniations, but in this case, we can explain the cause of the left leg pain. This is very clear. But in this case, the cause of the left leg is not clear. But I think in this case, there is narrowing of the intervertebral disc. Therefore, there may be, if we cannot see any herniation, there may be foraminal stenosis. Therefore, I would like to remind that there are different types of the herniations in this direction or in 4 direction. You can see in these cases also, you can explain radicular pain. As in our case, there is in this picture also, you can see narrowing of the intervertebral disc. Therefore, in all cases with narrowing of the intervertebral disc, we need to check foraminal foramen for stenosis or osteophytes using MRI and also computed tomography. This is very important. So the other problem in this case is low back pain. Actually, we can see here some modic changes. I would like to show, according to me also, these are not infection. I think these are modic changes. I would like to show you on only to remind in type 1, as you can see, the changes are hypo in T1, hyper in T2. Probably in this case, this we may have one type 1. In type 2, we have hyper and hyper in T1 and T2. And in type 3, all are hypo. So in this case, we don't have T1 weighted MR images. Therefore, I am not sure if this is modic type 1 or 2, but commonly, modic type 1 are much more painful than others. This is so because I would like to show you in type 1 changes, I mean hypo in type T1 and hyper in T2, there is fibrovascular changes, and this causes inflammation and edema. Edema is very painful, but in type 2, there is only fatty infiltration. There may be pain or may not be. But in sclerotic changes, actually, this is something like fusion, and therefore, it's not actually much more painful. The most painful is type 1, but most cases of the type 1 convert to type 2 in 18 or to 24 months. Therefore, in this case, we need to see T1 weighted changes. Is the risk of infection? There are some papers talking about the bacteria within the disc in modic changes, but actually, in case of bacteria, all these bacteria are anaerobic, but modic changes are aerobic area and not good for bacteria. So in differential diagnosis, I think beside of all this MRI image, I need computed tomography in order to see if there is any sclerotic changes or osteolytic changes. We need to see sedimentation, CRP, TB, and Brussels-related parameters. And for this case, I think there is no infection. To me, this is modic changes. Probably because of the disc narrowing, there is foraminal stenosis and reticulopathy, and I start anti-inflammatory medicines and may recommend physical therapy. Thank you.
Thank you very much, Said, for this introduction. I would like to show that we have negative results from the L5 biopsy.
Yeah.
And from the scans, we can see that the rest of the discs are in very good condition. So actually, we have one level disease, as we call it. Only the L5S1 disc, which is maybe the most important, since it connects all the forces from the pelvis to the rest of the spine. So what would be your opinion of treatment, conservative or surgical? And what?
Actually, I said my opinion. I think this is modic changes, conservative. But if computed tomography, others MR images and blood tests show additional information, of course, we can change our strategy.
What about the fact of one level disease and that after 1 year it deteriorated? Do you have any fear that the increased forces from the L5S1 will start to deteriorate the L4-5 disc?
Actually, I would like to go to the back. You can see here, actually, L4-5 disc is very healthy.
Yes.
Here we have a black disc in L5S1, but all other discs are healthy. And this is so especially is important because the case is 40-year-old, middle-aged female. Of course, there is risk, but we don't have any information about the job and lifestyle of the case.
But we know that he's only 40 years old.
Yes.
Relatively
young.
Yes, and he has to work.
Yes.
Ruli, I would like also the opinion of Ruli Hanaf.
Okay, thank you, Dr. Vasilis. Yeah, first of all, I think this kind of disease is not infection. It's not TB also because the lesion is only at single level and the end plate, lower end plate and the upper end plate is still good. I don't think it's TB. And most of the time, the TB will influence and make an abnormality in the central. It's not. It's very, very rare. It's comes out with lateral symptom like this. So, but I agree with Dr. Said that this is exactly a foraminal of stenosis of the foramen cause the symptom, and there's a decreasing of the height of the vertebral disc, though it's make the decrease the height also of the foramen, so it's lead to the symptom of foraminal stenosis. We can do if we have X-ray, good X-ray, we can do oblique X-ray to see the foramen and compare to the other level up and down of the foramen, and CT is better, I think, to see the foramen itself. But I'm not against the biopsy, but I think the problem of this patient, this is localized degenerative disease because there's a sign of dehydrated also. If I agree, I would do a CT scan just to confirm is there any stenosis of the foramen, and I would do surgery for this patient. I would increase the height and put some device. I think like P-leaf or T-leaf, and because the symptom is not come from the disc because the disc also already dehydrated, but the symptom come from the stenosis. But I would prefer surgery for this patient, single level, and increase the height of the foramen.
We need to say that putting a T-leaf will increase also the lordosis of the disc because L5S1 is supposed to have the greatest, to support the lumbar spine with the greatest lordosis of 15 to 18 degrees. So
yeah, exactly. We can correct. Oh, sorry.
And we can see here, even though the patient is lying for the MRI scan, that the lordosis is minimal for the whole lumbar spine because of that lack of lordosis at L5S1. So by putting a T-leaf, we give a more mechanical position to the whole lumbar spine.
Vasilis, I would like to state something.
Yes,
First of all, in order to exclude infection, actually you can see axial view. There is no additional information supporting infection here in the axial view. Actually, we don't have any contrasted MR image also.
yes.
Therefore, if there is suspect for infection, first we need to see everything. For treatment of the radiculopathy and L5S1 nerve root block may be helpful. And also, on the other hand, as we said, lumbar lordosis might be affected in this case, but we need to see standing X-rays.
Yes, I said that
because,
the MRI scan is
yes,
flat.
Yeah, okay.
Yes, I just wanted to show all the possibilities because this is a case of back pain and sciatica, but not neural paresis. Okay. Thank you very much. Thank you very much, Said.
Any other question? No question, yeah? Okay.
We will continue with the next case. I would like to call, please, Said, and share your screen.
Okay, I stop the sharing.
And I would like to ask Jeremy Omoro Ondari. Dear Professor Salazar, would you like to make some comments? We cannot hear you.
Yes. Hello.
Hi.
Thank you.
Hi.
Thank you
for sending your case to us.
Yes, thank you to consider my case because it was a problem. The patient was painful, and it's not a radicular pain. It's more a local pain, but the patient does not collaborate well. We performed all the blood tests were negative. We also did a biopsy, a pedicular biopsy. Results were negative. We studied for TB, was negative, and the patient continues to be painful. And lastly, the patient showed me an MRI from 5 years ago, and the image is almost the same. So maybe I would consider some cases of immunological disease or rheumatological diseases. I don't know what's your consideration, or should we proceed and do an open biopsy of this case? Do you think it is advisable to do an open biopsy? What are your thoughts about this? Thank you.
In my opinion, the fact that all the other discs are in excellent condition, there are no osteophytes and no other indication, that excludes rheumatological pathology. And since the MRI scan continues to be the same, I would just have a discussion if he wants to continue conservatively or have some kind of operation. I don't know if the other gentlemen want to add something.
And what about a prophylactic antibiotics for this lesion? Do you think it's advisable or is not?
There has been a couple of papers from Holland, as you remember, 5 years ago, advising that this kind of cases might be due to infection, and they were giving antibiotics for 2 months.
Mm-hmm.
And they showed a reduction, but this was not confirmed. Let's ask Professor Paterakis. Can you tell us your opinion? Yes, please, because you have raised your hand. Kostas, yes, proceed. We cannot hear you. You have to unmute. Imad,
Okay, you can hear me now, yes. Okay, hello to all. I would like to ask you, we have seen only a T2 image. What about T1 images and MR contrast enhancement? Because you are speaking about infection, do you have this kind of images? T1 and T1 also after contrast enhancement?
There was no enhancement of the contrast MRI. Yeah, it was the same image. But
No
we
enhancement.
couldn't.
And on T1, what type of modic was? Was 1, was 2? What kind of modic?
Just now I don't remember, but the contrast studies did not show any kind of abscess or obvious infection.
okay.
Because it seems like being a degenerative process, and after performing also standing views to assess sagittal balance, maybe the solution will be to treat it with TLIF and instrumentation, the compression, TLIF and instrumentation. Anyhow, after performing conservative treatment and not achieving any improvement.
Okay, thank you. Thank you so much.
Thank you very much, everybody. We have to continue. Is Jeremy Ondoro here to present the second case? Yes. Imad, can you identify
Yes, sir. Yes, sir. He's here.
Jeremy?
I can present. Kindly allow me to present my screen.
Hi, Jeremy.
Yes,
Yes,
yes.
you can share the screen, Jeremy.
Okay.
And please present yourself to the rest of the attendants.
Thank you so much. Can you see my screen?
Yes. And you can hear you well.
Okay. I hope my screen is visible. My name is Jeremy Omoro. I'm a neurosurgery resident from the University of Nairobi, currently in my 6th year of training. So I'll present the case of a 47-year-old male. He's a right-handed man he's a waiter by profession. He presents with a 3-year history of axial neck pain and associated left upper limb weakness and numbness that was especially on the thumb and the index finger. He also reported that he had a loss of dexterity of that left hand. He had associated muscle of the left deltoid region, but it was also noted that he has wasting on the forearm, the arm, as well as the thenar and the hypothenar eminence. He also reported that he had urinary incontinence and an abnormal gait. On his past medical history, he was a hypertensive patient on nifedipine. Okay, so examination, he was a fair general condition. He was alert. He was not pale or jaundiced with a BMI of 22. His GCS was 15 with normal pupils that were reactive to light bilaterally. He was noted to have an abnormal gait. I will show you the images later on. He's on his spine examination level at the C4 level, and on his motor exam, he had a left upper limb weakness, MRCS grade 3, and he was noted to have deltoid wasting, and his tone was reduced on the same left upper limb. He also had reduced reflexes of the biceps as well as the triceps. On his provocative test, they were all negative, the span as well as the Lemite test. And he also had a positive Hoffman and a positive inverted supinator reflex on the left upper limb, as well as a positive Tromner test. These are just signs of a upper motor neuron disease. On his lower limb, he had no clonus and his Babinski was downgoing. His other systems are essentially normal. So I graded him as an MJY grade 11/15 and an uric grade 2. These are just representative images of the patient. So this is him standing on the lateral view. You can see that his right upper limb is able to lift it, but when you look at the left upper limb, then is not able to raise it beyond this around 45 degrees. You can note on his examination from the back, you can note that he has this scoliotic curvature of the thoracic spine. You can see that his left shoulder is relatively higher than the right. And you can also see that if you look keenly on this pelvic level, it seems like the right side is relatively higher compared to the left side. So this is just a closer view of his left upper limb. You can see that his deltoid is relatively reduced in bulk. And when you see him from anterior, you can also see that there's relatively wasting of muscles of the left upper limb compared to the right. So when you look at these hands, you can see that there's relatively wasting of the thinner eminence on the left compared to the right, as well as the hypothenor eminence. So those are the main things that I noted on his clinical examination. So these are just representative radiological imaging. These are MRI scans from the right parasagittal, the mid-sagittal, as well as the left parasagittal. So what you can see clearly is that there's loss of the cervical lordosis. You can see that there's relative reduction in the sizes of the intervertebral discs from the level of around C4. And you can also see that there's narrowing of the thecal sac from the level of C2, C3, C4, C5, C5, C6, C6, C7, and C7, T1. You can see that there is severe canal stenosis. On the mid-sagittal cut, you can see there's representation of the loss of the thecal sac, and you can also see that there's disc herniation more relatively on the C6, C7, C7, T1. On the right parasagittal, you can still demonstrate the herniation of the disc. You can also see that there's relative change in the high intensity of the disc, but we are going to compare with the T2 so that we can be able to grade the modic changes. When you come to the T2, you can relatively see the disc herniation that I presented in the T1 scan. And one significant finding you see on the level of C4, C5, you can see some T2 hyperintensity signal in the spinal cord. The posterior ligamentous structures seem to be normal. You can also see that the disc herniation, as I said, is reportedly to be significantly higher on the C6, C7, C7, T1 compared to the other higher levels. These are axial scans. And you can also, you can see is that there's narrowing of the exiting neuroforaminas, that there's significant canal stenosis. You have seen that there's obliteration of the CSF signal around the cord. So in summary, you can see that there's multi-level C4, C5, C5, C6, C6, C7, and C7T1, bilateral neuroforamina narrowing. It is predominantly higher in the left than the right. The associated facet joint hypertrophy with a T2 hyperintense signal at the level of C4, C5 with multi-level degenerative disc desiccation. So for my questions to the board is, first, do we have a role of surgery for this patient? And if we have, then what are the goals of surgery for such a patient? Then secondly, what are our surgical approach would we use? Would we go anterior? Would we go posterior? Or would we go combined anterior and posterior, that is 360 degrees? And if you are going to go for this surgery, then how many levels of fusion are you going to go for? Thank you.
Thank you, Jeremy. So, if I understand well, we have a young patient with degenerative cervical spine, compression of the spinal cord. Jeremy, please continue to show the scans.
Okay.
Because we are looking at your screen and you are the only one who has it.
Sorry. Okay. So
yes.
These are the scans.
And we have also myelopathy showing at
Yes.
at least one signal. Can I ask Ruli, what is your opinion about this case?
Yeah, thank you, Dr. Fasilis. Jeremy, this first of all, I want to know this: is this patient have a vegetative disturbance or no? I missed that. Maybe if you already mentioned. Does this patient have
Yes.
vegetative disturbance?
Yes. He has an abnormal gait. Oh, that's what you're asking?
No, I mean the vegetative disturbance. I mean the urination and the defecation. Still normal,
Yes. Yes.
or
Yes.
is there
Yes.
any
There is investigation and
normal?
there is modic 3 changes.
No, I mean how the patient has urination and defecation. Is it normal or no? Is the only
He
symptom
says,
is the left side hand?
Ruli, he says that urinary urge, incontinence, and abnormal gait. So he
Normal.
has some
So,
incontinence.
incontinence? Sorry, my signal is not that good.
He has some urinary urge
Oh,
incontinence.
okay. This patient has already examination for EMG or no? Do you have an EMG for the exact level of the symptom?
No, we don't have.
Electromyography?
No, we
Oh,
don't
you
have an.
don't. Okay. Okay, doesn't matter. So, based on the clinical symptom that you have, that's the weakness of the deltoid, and the problem is from upper left hand to the distal. So I assume the most severe in this patient is the C4 C5. Uh, C4 C5 disc degeneration and C5 C6 perhaps. But if you want to do decompression, we can do laminoplasty, but in this patient, there's some problem because this patient is still very young, quite young, and then the symptom is not tetraparesis. I can see the right hand, and all the leg is still normal. Five motoric 5, I think, and the symptom is only left-handed motoric paresis. I would and the patient also has the lordotic. The lordotic is not good. It's straight neck. The patient has straight neck, and it's not good to do laminoplasty or laminectomy multi-level at the first time from posterior. And then the other, we can see this patient has edema. In T2 imaging, I can see there's edema, and then sign of Batman logo from the sagittal view in four body of the vertebra. It's like a multi-level process. So I don't think it's wise to do the compression at the first time from posterior, because you will ruin the posterior tension ligament at the first time while the anterior part is not so good. So I choose to preserve the posterior function, and I would not do the posterior ligament rupture and decompression for the first time. I will choose two-level discectomy C4, C5, C5, C6. And then after surgery, so I choose anterior first, and then we can do follow up for the patient. And then if it's still the paretic is still there, and then we can think about decompression for laminoplasty from posterior. But at this, do you have CT scan to see all the quality of the bone, or only MRI imaging?
We only
Jamie,
have MRI images, no CT
only
scan yet.
MRI.
Yes.
Okay. If you
Okay.
can do CT scan, you can add more CT scan to see the quality of the bone, but I would choose anterior now. The goal of surgery is decompression, C4-5, and C5-6 level. Thank you.
Thank you, Ruli. Said, Professor Said Naideri.
May I see T2 weighted MR images? Next slide. Okay. It is very interesting. This patient is relatively young. Yeah. How are actually I forgot, but I can see here compression of the vertebral bodies. These are not common for relatively young people. There may be another problem causing osteoporosis, yeah, secondary osteoporosis. You can see here compression. You can see compression better in the T1 weighted. Can you go back again?
And we have a great production of osteophytes, anterior osteophytes.
No, but here you can see here some compressions in these vertebrae. You can see in C3, C4, C5, and again in T2 weighted, I can show you signal changes at the level of probably C4, 5. And also many disc herniations in the C5, C6, and C6, C5, C6, C7. In the right image, you can see herniations causing radiculopathy. And in the middle image, you can see signal changes. Actually, in order to see signal changes in detail, you need dynamic MRI. MRI inflection position can enlarge the spinal canal, and you can see all details of the signal change, myelomalacia. But clinically, this case has urge incontinence. This is probably due to myelomalacia here, and also patient has weakness in not only deltoid and in the distal as well, and both biceps and triceps reflexes reduced. That means the compression is in all levels. As there is compression of the vertebral bodies, I think laminoplasty is not a good option in this case. In this case, we can try to do either posterior, I mean laminectomy plus stabilization, or corpectomy. Probably I choose to do laminectomy because lordosis is not bad. After laminectomy, you can increase the lordosis, and if there is some another symptom after this surgery, you may do probably 1 or 2 level discectomy from the anterior as a second surgery. But my first choice is posterior.
So your first choice is to do decompression in all levels, not in 2 levels. Where is the
3, 4, 5, 6.
All right. And probably because he already has a conservation of the lordotic cervical spine, you prefer to go from the posterior. And
But after putting the screws, actually I increase the lordosis in this way, and then I put rod and fixate it.
Okay. Thank you. I would like to continue with the next case from Kostas Paterakis, because it has a similar subject and we will be able to do a common discussion too. Konstantinos, can you hear us? Professor Paterakis, yes.
Yes, I can hear you. I would like to say, okay, hello to all again, and just to share my screen. Well,
Professor Paterakis is in the University of Larissa, professor of neurosurgery, devoted to the spinal surgery. And he was also the director of one of the cadaver courses from the World Spine 4, I think.
do you see my screen
No?
No, sir.
now?
Yes.
Yes, sir. No.
Okay.
No,
I'm
not that. You should start from the beginning, please.
Yes, okay.
Thank you.
So this is the case of a 60 years old male unemployed. His past history was characterized by an ascending aorta replacement and aortic valve reconstruction back in 2008. In 2016, he had an aortic valve replacement and a mitral valve reconstruction. He suffered from a mild COPD. He was hypertensive with cardiac insufficiency, and he was on treatment with Salo-Spears syndrome, Lasix, and carvedilol. He had a 10-month history of gait unsteadiness, decreased dexterities, upper and lower limb dysesthesias, urinary incontinence gradually getting worse. Furthermore, he had episodes of falling from his height. On examination, his mental status and cranial nerves were normal. His MRC were on the upper lips 3-5 in both arms from the level of C5 and 4+ after 5 in the lower limbs. His reflexes were increased. The tone according to the Ashworth scale was in the upper lips 2 and in the lower lips 3. The sensation was decreased in the upper limbs at C5, C6, and C7, on the right side more than on the left side, and he had Hoffman, Babinski, and clones bilaterally. His SASA score was 4. His modified Japanese Orthopedic Association scale was 18 after 8 after 18, suffering from a severe myelopathy. His Nuric grading was 4, and his NDI was also 36 after 50, meaning a 72%. This is radiological imaging of the patient. Unfortunately, we don't have MRI because he had a metallic valve, and the MR doctors denied to perform an MR scan. They asked for a permission form from his cardiac surgeon, but the patient did not provide with such a form. So we had only CT scans. You can see here the CT scan, and on the upper left side, you see an X-ray on extended position, showing practically a rigid fixation of the spine. So how would you have treated this patient? First, conservatively or surgically? And then we can discuss for the approach.
Thank you, Konstantinos. So we have a fixed deformity in severe kyphosis, and we have continuous compression with myelopathy of the spinal cord and deteriorating neurology. Can I ask you, Said, your opinion?
Actually, this is fixed deformity case
Yes.
with severe myelopathy. Your JOA score is 8. This is severe myelopathy. And I have seen the wires for thoracotomy. That means the patient and ASA score is 4. That means there is high risk for surgery, high risk of anesthesia, high risk of surgery as well. Actually, if we exclude the risk of the anesthesia, we have only fixed deformity. For such a case, first, a posterior osteotomy and laminectomy is needed. We may try to do good correction and fixation with pedicle screws. And then go after a little correction, we can go to the front to add anterior strut as well. But in this case, I think both risk of anesthesiology and risk of surgery is very high. And therefore, actually, I do not recommend surgery in my practice for this case.
So you would do conservative treatment and corticosteroids?
Maybe, but you know, if you touch to this case, this is a Catholic marriage. You cannot divorce. There is high risk.
So you are married to the patient.
Yes. Well, by Turkish we say by marriage.
In a good way or in a bad way, I don't know. And
yeah. This is my opinion.
So conservative treatment and no decompression. Can we see the previous slide, please, Konstantinos? Yes.
So here is C3, C4. You have some kind of spondylolisthesis or maybe a neglected lax facet. I'm not sure because I cannot understand with axial views. They are too small to understand. But this may be due to dislocation, neglected unilateral dislocation in the past, or degenerative spondylolisthesis.
Was bilateral dislocation. Yes, I have no other images, and you are right. The patient has been informed that it was a high-risk operation, but he insisted because, as he said, he didn't want to live to have this quality of life. He couldn't stand anymore, and he wanted to take the risk.
According to the kyphosis of lordosis of the cervical spine, usually they say that this dictates the approach if it's going to be anterior or posterior. In the previous case, we had a good cervical lordosis. In this case, we have a fixed severe kyphosis. Would that be guiding us to an anterior osteotomy or vertebrectomy in order to do both decompression and correction of the deformity, or because of the severe myelopathy and the low JOA score, we should try to do a minimal decompression possible?
So, Vasilis, I will kind of chime in quickly. I don't know how to raise my hand on this on Zoom, but I've had a couple of similar cases, and I cannot comment on the medical clearance for this patient, but assuming this patient can be medically cleared and can be a good surgical candidate, these are the surgeries that I tend to do as 360, so anterior, posterior. So in this case, I would start with anterior. I would try to distract 3-4. I would put a graft in there that is only attached to one of the bones, because I don't want to be doing a regular ACDF, for example, fix them in a kypholic deformity from the front. And like Dr. Naderi said, it's a lot easier to get lordosis from posteriorly than anteriorly. So what I would do is put them in traction, go anteriorly at C3, C4, put a graft, an ACDF graft there, preferably a hyperlordotic one if you can, and attach it with a screw only to one of the vertebral bodies, in this case, probably to C3. And then go posteriorly and do a laminectomy, decompress that severe stenosis at 3-4, and try to induce more lordosis in this case. But that's how I would treat it.
Andrew, C4, as we see, the superior posterior corner of the C4 is the one that does the greatest stenosis.
Correct.
How would you think of doing a vertebrectomy at the C4? Do you think this is a major operation for a patient like this?
I think so. I think it's a lot easier to try and distract with Casper pins after traction and try to put an ACDF cage at C3, C4. You can, of course, do a C4 corpectomy, but it's a lot more morbid in a patient like this. I think you can fix some of that stenosis anteriorly by bringing C3 back on C4. And that's where you're opening the canal and reducing the stenosis in the canal. And then you can go posteriorly and induce more lordosis and do more decompression.
Thank you. Anyone else to comment on the surgical approach and the levels of fusion?
Can I give my comment, Vasilis?
Yes, please, Ruli.
Yeah, I agree with Andrew regarding the problem of the cardiac insufficiency and the old patient, 60 years old. I don't think I would like to do a prone position in this patient. So I would like to avoid posterior decompression, but indeed we need to do surgery. I agree to do surgery in this patient, but I will choose to drill out and vertebrectomy the C4, C1, C4, C5, yeah. 2, 1, 2, 3, 4, yeah, C4, C5. I will take it out all and clear, do the midline decompression of the body of the vertebra and put long cage and long plug fixation from the anterior and try to correct the lordosis as possible, but I would not do the posterior approach in this patient. Then I will observe again after surgery, but only do the anterior decompression.
Thank you, Ruli. Konstantinos, shall we continue with your presentation?
These are the possible approaches. So because I'm going back again, sorry, the X-ray on extension is with a support under the neck, and there is no extension. So we thought that even with traction, it would be difficult to restore the alignment because it was a chronic condition. It was something that happened 1 day, 2 days before. Furthermore, the angle of approach, if with an anterior first approach, will be very cumbersome because of this angle. So we prefer to go first posteriorly, performing C3, 4, 5, and 6 spinous process removal, C2, 3, C4, 5, 3, 4, 5, 6, and 7 laminectomies, and C3, 4, and 5 facetectomies. After that, we went anteriorly. We performed the C4, C5, C5, C6 discectomies and C4 corpectomy, and inserted an expandable gauge and plate. And finally, we turn again posteriorly. We fixed the spine with C3, 4, 5, 6 lateral masses, lateral mass screws. Anyway, during the compression, during laminectomy, a decrease of more than 50% of EPs was noticed. At that time, mean arterial pressure was kept above 85 millimeters of mercurium. There was no hypothermia, no traumatic event. And we thought at that time that might be due to the fact that we may have a bowstring effect. So we proceed in order to restore the alignment. But even after restoring the alignment, the EPs did not recover. And we proceed with the anterior approach and then with the posterior approach and finish the operation with no recover of the EPs. So, after surgery, the patient was woke up and he was practically tetraplegic. but there was no epidural hematoma because this happened intraoperatively. There was no instrumentation failure, and we didn't have any hypotension or hypothermia intraoperatively. So what could be the causes? According, yes, does somebody want to start? Yes.
We have a case with severe stenosis in 4 levels, great osteophytes, that these probably tell us that this stenosis has been there for a long time, and myelopathy, that means an edema in the spinal cord. That is before the operation. Any comments, please?
What were you doing exactly when you lost the motors?
Sorry?
What were you doing exactly when you lost the motors? What you said you were doing a laminectomy, but what exactly was going on? Were you like, was the bone already off, or was it during taking off of the bone?
We just check for the blood pressure and the case of hypothermia of the technicians check the EPs if there was a problem. There was no problem. So, as I said before, we thought that by improving the alignment, maybe we could have improved also the EPs, because at that time, we thought about a bowstring effect. A bowstring effect, as you know, that is in cases of severe kyphosis, the spinal cord does not shift posteriorly because of the attachment of on the degenerative spine, on the osteophytes. And in these cases, you have a deterioration. Therefore, we kept going in order to improve the alignment. All the other parameters remain stable.
Yeah, I've seen or heard of one before with a similar story, also was kyphotic in the cervical spine. And what the patient ended up having was a subdural hematoma, which of unknown etiology. So one thing you could do is intraoperatively, if you have an ultrasound, you can check with an ultrasound to see if there is any blood intrathecally. And the other possibility is reperfusion injury. So, the spinal cord is compressed for a very long time, and now it's decompressed, and now you get some kind of reperfusion injury. But usually you don't get tetraplegic or tetraplegic from that. I mean, you get some kind of small focal deficit, but not that devastating. So this would be my thoughts.
The patient, as I said,
Continue, Konstantin.
tetraplegic and remained intubated in the ICU. And the next morning, he woke up. He had he could move his hands up to C6, 2 after 5 on the right side, 3 after 5 on the left side. So he showed an improvement, but he was not extubated because his breath was shallow, and we think that he was better to remain intubated. As you said before, we ended up thinking of probably of a white cord syndrome, meaning a reperfusion injury, since the realignment was restored. This is not from our case. We didn't have an MRI. This is from another case, as you see, in another case with white cord syndrome, where you have the edema of the spinal cord. Anyway, the patient during the night of the postoperative day, he had a cardiac arrest, and he underwent the CRP for 10 minutes. He recovered again, but on day 2, he was again tetraplegic. He could move hands, not only his shoulders. He stayed in this condition for 2 months and finally passed away due to respiratory infection. I have chosen this case just to discuss about the white cord syndrome. As you can see here, there are several articles reporting on this syndrome. And there is also a review from Al-Qahtani and Daltri in a recently published article with 17 such cases, 12 of whom did not recover. They remained deteriorated. And in another article, there is the pathophysiology for those who want to see it. Can I continue, Vasilis, or can I
Yes,
stop
please.
here? So according to Matkour and Alti from an article in World Neurosurgery in 2020, the pathophysiology of reperfusion injury includes ischemia, alterations of the vascular architecture, endothelial cell impairment, disruption of the blood-spinal cord barrier, and oligothrocyte and neuronal cell apoptosis. Now, what are the postulations? The postulation is that reperfusion triggers an inflammatory cascade, the releasing of free radicals, a breakdown of a phospholipid membrane, disruption of the blood-spinal cord membrane. So we have the presence of inflammatory mediators, including TNF-A and interleukin-1B, resulting in oxidative stress after reperfusion, and finally, in neuronal damage. It has been supported by some authors that by increasing the mean arterial pressure, you may improve the condition of the patient. But if you have a reperfusion injury, are we sure that the reperfusion, increasing the mean arterial pressure, will not result in a detrimental effect, in an even more severe damage? What is your opinion? Of course, we can administrate steroids in high doses according to the NASCIS protocol. In our case, we administrate dexamethasone 8 milligrams three times a day for a few days, but we didn't see any improvement. What is your opinion?
Yeah, my understanding is that keeping the map up is the way to go because you don't want to cause any ischemia to the cord or further ischemia to the cord. But of course, not too high. So usually the number we use is about 85 or so for the map goal. I think hypothermia in this case, probably the first 2 or 3 days, is not a bad idea either to decrease the metabolic demand for the cord. So, keep MAP up and induce some kind of hypothermia to try and recover. But like you said, some of those injuries are non-recoverable.
May I ask some question?
Of course.
Did you operate under neuromonitoring?
Yes, of course, VPs.
Could you see changes during the surgery also?
Yes, I said before that we had a decrease of EPs intraoperatively of more than 50%, both MEPs and SEPs.
Before, I mean, during the posterior surgery or anterior surgery?
During the posterior surgery.
During the first surgery?
Yes, during the first phase.
Okay. And did you use steroid during surgery?
If we use what?
Did you use steroid, cortisone?
Yes, of course.
Both during surgery and NASCIS after surgery?
Yes, both and after, but we administer only dexamethasone.
Okay.
So
It is happening, this similar case to me about 15 years ago. And I think it's not a perfusion injury. It's about, because if you can see, I have the similar case like this 15 years ago. C3 and C4, it's C4 tend to move posterior. It's tend to slip. So when we do the laminectomy first in this kyphotic cervical, the C4 will slip to the posterior and the C3 will slip to the anterior because they lose tension in the posterior part, and the spinal cord will bowing and buckling. So what happened? I think because it's happened to me. The anterior spinal artery is buckling and compressed, and it's like anterior spinal cord syndrome. And the paretic ischem is not because reperfusion, but because it's a vascular block when the C3 slip to anterior and C4, C5 clip to the posterior after laminectomy. That's what I'm thinking of, because it's sudden after surgery, but it's not happen inside the surgery. On the time of the surgery, I think it's happened after 24 hours after surgery. Is it, Professor Konstantinos?
What happened intraoperatively? What happened intraoperatively. We checked the X-rays with X-ray. There was no further slippage, and furthermore, the patient was fixed with a Mayfield.
Oh, fixed with Mayfield. Okay.
It was fixed.
But the syndrome is like the compression of the anterior spinal cord, so it's become tetraparetic. I don't know if we have a case like this. Do we need? Can we do like emergency traction after surgery to maintain it, even though the X-ray is not giving abnormality? Does anyone agree to do
To do an emergent what? Emergent?
Slide traction.
Traction, the fact, I believe that this was a white cord syndrome because, as I said before, on day one, he had already an improvement. He could move his upper limbs, although with practically on the right side was 2 after 5 and on the left 3 after 5. But I think if he didn't have this cardiac arrest during the night, he will get recovered further, I think, is my opinion. But since he was a patient with a severe heart disease, he had this CPR for 10 minutes. So this further deteriorated the perfusion of the spinal cord. That's why he didn't recover.
Okay.
Yeah.
Thank you very much.
Vasilis, allow me, I have one more slide just to give a food for thought for all the participants. This is a clinical trial that took place more than 10 years ago, and it reports the effects of remote ischemic preconditioning on biochemical markers and urologic outcomes in patients undergoing electric cervical decompression surgery. It has been published in the Journal of Neurosurgical Anesthesiology. According to this article, remote intermittent ischemic preconditioning is found to induce ischemic tolerance not only within the same piece of tissue, but also in distant tissues as well as distant organs. And it has been used in cardiac surgery and in transplantation surgery. The remote ischemic preconditioning consisted practically in this study of 3 5-minute cycles of right upper arm ischemia, which was induced by an automated cuff inflator placed on the right upper arm and inflated to 200 millimeters of mercurium, with an intervening 5 minutes of reperfusion during which the cuff was deflated. And the authors checked the levels of the neurospecific NOLAS and the S100 protein, which we know that they are increasing after nervous tissue damage, and they are directly related to the damage. So the authors reported that this study has shown that this intermediate preconditioning mediated by transient upper limb ischemia can reduce serum levels of S100 B and neurospecific NOLAs in the perioperative period in adult cervical spinal myelopathic patients undergoing elective cervical decompression surgery. The neurologic recovery in the group of remote ischemia was better than that in the control group at 7 days and 1 in 3 months after surgery. And this figure shows the differences. Anyway, I'm showing this just to say that maybe it would be useful to try a clinical trial, a multi-center clinical trial, because it needs many patients to have a reliable conclusion.
Thank you very much, Konstantinos.
Yeah. It's a great case. Thank you.
Bye-bye. Thank you.
Let us proceed now with the fourth case. since we have 1 hour and 15 minutes now, can Professor Ruli Hanafi go on with his case, please?
Okay. Does the slide in Imad? Imad, please share.
Right. Imad, can you show us the slides?
Sir, I don't have the presentation.
You don't have the presentation. All right. So Ruli, you do not have the presentation.
Yeah. I don't have it. Sorry. Which case now?
Sorry?
The fourth case is which case, Vasilis? I don't know.
Yes. The first case is from Hassan Sadiqin Hospital.
Oh, who sent the case? Dr.
Michael.
Dr. Michael?
Yes.
Yeah. Dr. Michael, can you read the case?
Is Dr. Michael here, please?
Okay.
Yes, please.
Yes, please, Dr. Michael.
Yes. Thank you.
Good evening, everyone. Good evening, Dr. Hanafi Dahlan and Professor Vasilis. My name is Michael, and I'm a resident from the Department of Neurosurgery, Hassan Sadiqin General Teaching Hospital. This is our cases. This was a 56 years old male who presented with weakness of all extremities, which the onset about 18 hours before admission. The patient fell from the height of 5 meters and weakness of all extremities. From the examination, we found the hypoesthesia at level C6 and below, with the sacral reflex normal, Babinski reflex was negative, and vegetative within normal limit. And from the upper extremities, we found the motoric strength was 4 in both the extremities and the lower extremities. We also found the strength of 4 in both lower extremities. And from the CT scan, cervical CT scan, we found the malalignment and the burst fracture about 5 and the level of C5 and C6. And the patient had a translation injury positive at the C6 until the T1 and the bilateral facet lock C7 until T1 and canal stenosis. And this is the cervical X-ray of the patient. So the question for the board, what is the best surgical approach for the patient? Is it for the anterior, posterior, or for the both anterior and posterior of the combined approach? That's all. Thank you, Professor Vasilis.
Thank you. Ruli, what would you like to comment on this case?
Yeah. Do you have another examination, Dr. Michael?
I'm sorry, doctor, we don't have another examination for the patient.
Yeah, please show. No, the other CT scan, sagittal alignment, axial.
No, the patient don't have another examination, doctor. Only the CT scan from the another hospital and the cervical X-ray from our hospital.
What about the best factors at C4, C5? Sorry, yes, C5, C6. Do they have any part of the bone going to the canal and making compression? Or it's the severe event of this injury is the listhesis at C7, T1?
Unfortunately, we only have these images for Professor Vasilis from the outer hospital.
I think Andrew or Constantinos can comment first because this patient was come to from my hospital. Maybe you guys, friends, would have a comment.
Mhm.
Can you go back to the other images you have? And you said you don't have any MRIs or anything?
No, we only have a CT scan and cervical X-ray.
Here on the X-ray, we do not even see the dislocation of the C7. We see a great foramen behind the C7, which means that we have a disruption of the posterior facets, but we don't see anything else. And the C4, C5 vertebrae, they have a big osteophyte, but they don't show a huge compression or burst fracture.
Can you show another picture that showing the restasis from the C7 T1 level?
Let's make the discussion that behind, as we can see here, behind C7, we have the foramen, the disruption of the facet joints. In this fracture dislocation image that we have of the C7 on T1, who would go from anteriorly and who would go from posteriorly?
Or put them in traction
Yes.
and see if you can even re-establish that somewhat of a normal alignment. I think if you cannot re-establish, decent alignment with traction, then you're going to have to go posteriorly first. I think it's going to be very hard to treat this anteriorly if the alignment remains like this. You're going to have to go from the back and drill the facet joints and try to re-establish their alignment.
Any other comments? Thank you, Andre. I would like to go anteriorly, and because it's third grade spondylolisthesis, make a vertebrectomy of the C7 and make an anterior fusion, and then go and decompress from the posterior side and make a fusion again. Any other comments? Konstantinos? We don't have.
Do we need to approach Fatilis under the posterior, or we just choose one of it? Because this is a new patient.
Yes.
Just do we need to both approach stabilization, or only anterior, or only posterior? We can choose, or do we need do both? I don't know. I'm asking.
In favor of Andrew Fanus, I would say that if we have an MRI scan and that favors the posterior approach, then in this case we need to do also an anterior approach. But if the situation is better and we can do only the anterior approach with a vertebrectomy and good stabilization, remember that this is the cervicothoracic area and it needs extra stabilization in order to really stabilize it, because the forces are great to go from the kyphosis of the thoracic area to the lordosis of the cervical area. I have done a couple of cases like that came to me with broken posterior screws and with ACDF from the anterior. And in order to do the revision and proper stabilization, I did the vertebrectomy. And then from the posterior, I went 2 levels above and 2 levels below in order to be on the safe side for the stabilization of the cervicothoracic area.
No, I agree with you
Yes.
completely that you need extra stabilization at the cervicothoracic junction. My fear is when you see a grade 3 spondy like this, then you probably have locked facets in the back. So my fear is if I go anteriorly, I will not be able to basically unlock the joints. And then
I agree. I agree. That's why I said we need more images. And according to the images, we will see if we have to go first posterior and then anterior or the vice versa.
Yep.
Okay. Thank you, everybody. It was a great evening. Thank you for commenting and being with us. And we will give another appointment on the 3rd Sunday of March. Thanks
Okay.
a lot and have
Thank you. Bye-bye.
the rest
Vasilis,
of
Andrew.
Sunday.
See you,
Thank
Robin.
you.
Oh,
Thank you.
everybody.
Bye. Thank you, Ahmad.
Thank you, Iman.